You are listening to Walking Home from the ICU. We will be exploring how to save and preserve lives in the ICU. All opinions and views shared are unaffiliated with any organization. When COVID-19 came our way with concerns about isolation, patient load, and PPE, immediately physical and occupational therapies were dismissed from ICUs all around the country and world. In the beginning of March, I shared my concerns about the impact to patient outcomes such as survival, discharge disposition, and quality of life as a result of removing such vital therapies. Last episode, we heard Dr. Kenneth Hurwitz talk about his triumphant return home. This partially answers some of the questions we have received about how the Awake and Walking ICU has been treating COVID-19. Yet there is more to share. Today, I have Erica, one of our physical therapists, here to talk about the huge role physical therapy plays in helping a COVID-19 patient survive and thrive. Erica, our physical therapist extraordinaire, tell us about what you've been doing with these COVID patients. What are some of the challenges you faced, and what are you guys doing to keep people awake and moving?
So I think one of the challenges that we face is the ability to keep them moving to an extent that's going to help improve them being within the confines of the room. So we've bought arm, leg, stationary bicycles that both occupational therapy and physical therapy can use to work on aerobic endurance, because I think that's one of the things that we lose, not being able to walk the long distances. So that allows us to work in sitting position to allow them to be safe. It also allows us to work on something that we can challenge them more on during our exercise sessions in the room, and then also have them do homework of it, so it's safe for them to do when we're not in the room.
So they're sitting up in the chairs during the day, for the most part, right? And they are doing the arm bikes by themselves.
Yep. So we often will do it during the sessions to either progress or regress or teach them a little bit more about what things we want them watching to make sure that they're staying within a safe range with it. But it allows them to break up the activity a little bit more so that we don't always have to be doing everything exercise-wise during our 30 minutes that we spend with them. It allows them to break that up into smaller chunks, which is something that we see allows them to tolerate more activity altogether in a day if they can break it up a little bit more.
And then you brought in stools?
Like little step stools?
Uh-huh.
Yeah. So for patients that are going home and we aren't able to walk out to a normal staircase with them, being able to work on the balance and the hip and the thigh strength that it takes to be able to ascend stairs and be able to safely at least get into their home, as well as just have a slightly more challenging strength exercise for them in the room. We'll kind of act like Richard Simmons, get in there, put on their sweatpants, get them going up and down. Being able to step forwards on and off that stair, sideways on and off that stair, work just even on tapping their toes back and forth onto the stair to work on balance. And then just kind of what we would do before, but maybe focusing a little bit more on just standing strengthening exercises, having them use their body weight to be able to do things, and challenge their lungs in that way. Because as we know, when you use your muscles, you burn oxygen. And so even just that sometimes is a challenge for them. So,
yeah. And I've seen you doing squats with people.
Yep, doing squats, doing marching in place. I was just marching in place to John Philip Sousa for the last, 10 minutes. Just doing different exercises using their body weight, showing them ways that they can take those exercises that we do with them in the room that are maybe a little bit more challenging for their heart, their lungs, or their balance to a level that they can do also when we're not in the room. So just like the biking, we do the squats or the marching in place or the walking that we don't want them doing when we're not there, just kind of pacing in the room.
Yeah.
And teach them seated exercise. So having them march in the chair, having them do kicks in the chair, having them do thigh squeezes and butt squeezes and leg raises and things like that, so that they can continue to work those muscles at a safe pace and a safe level for them to do when we're not in the room. Again, breaking it up into smaller chunks.
Okay, that makes more sense because I'm not in the room with you guys. Usually I see you guys walking the halls. Now I don't see you walking the halls. yet I'm seeing these patients eventually walk out of their rooms once they are testing negative.
So before it was usually that the getting out of bed, the standing up onto your feet, the walking to and from the toilet, or the walking in the hallway was what we started with. You start with that. It gives you a gauge of, okay, what muscles are weak? What muscles do I need to do extra supplemental exercises with in order to make sure that they are able to do that either more independently or more safely? And that was our gauge. And then you'd say, oh, okay, well, they're having to use a walker because they don't have the hip strength to be able to stand up tall on their own, or they have trouble standing up. Their hips are weak. Okay, as they can tolerate it, we're going to keep getting them out of bed, standing them and walking them, but then we're going to, as we can, toss in exercises for hip strength and hip muscle endurance. And now it's more, we can't see you walk that far, so we don't really get that good gauge of where you're at, but we know that by not walking, those muscles are getting weaker. And so in some cases, they're able to do 3 sets of 10 for strength. And it's not that we're bringing weights into the room or anything like that, but we're just more proactively doing those exercises so that when they are to the point where they're able to walk those community distances, those muscles are A, strong enough to do it, but B, have the endurance to be able to hold on and help them do it so that they're not fighting their lungs and their muscles at that point. Yeah.
Oh, that's a good point. Yeah, 'cause you've already got weakened lungs and you don't want their bodies to get weaker.
Yeah. Because we know that this virus can cause catabolism of those muscles, and we know that, and so if we can do our best to front load these patients with that exercise, you might come in and you might have been a marathon runner or manual laborer and you've got that strength, but if you don't use it, you lose it. We all know that. Mm-hmm. And so we're kind of getting them on these exercise regimens to keep that strength so that when that maybe inevitable muscle catabolism happens, then they're starting off in a better place. That hole that they dig themselves isn't so hard to climb out of. And then, we're preventing some of those, we've got these different types of muscle twitch fibers. We're preventing those muscles from converting themselves. When you don't use them for certain exercises or types of functional activities, you're switching those those muscles to using different fiber types. So, we want this slow oxidative muscle fiber type in those big, large muscle groups to be able to do that aerobic exercise instead of switching to more anaerobic muscle fibers where they're building up that lactic acid and having that muscle soreness. So we're just kind of entraining those muscles to continue to be able to do exercise in that aerobic sense and be able to hold on for that long period of time, those big postural muscles.
And you're being so creative. I mean, how are you facilitating walking?
Honestly, I just kind of go by what the patients can do, if they want to walk to the toilet, sometimes that's the only walking they'll do. Usually we just do a lot of rearranging of the room. We get the feng shui going and we push that bed all the way to the side, the far side, as much as we can. We make sure we position the ventilators so that the ventilator is on the side of the bed where the toilet is. So if they are mobile enough, it's not just the fact that they're tied down to that ventilator that they can't get there. Because those ventilators have wheels and they can allow them to get around the room a little bit. So, we just kind of set up the room for success, push the bed, give us those big of a runway as we can, and they just pace.
Yeah. You're just kind of doing back-to-back circles in the room. Yeah. I see you to go to the door and back and door and back.
Yeah.
Amazing. I saw you walk into a patient's room with a golf set, like a little putty golf set. What was that about?
I think it was a bedpan and a cane. But just with anything that you're going to do, you got to be able to tap into what's going to make that person want to do it. Of course, I can come in with all the sunshine I want and I can ask a patient to exercise, but unless it's meaningful for them, they're not going to buy in and they're just going to grimace and get through it. But if you can make it relatable, and it's, something we always do as PTs, we're trying to make it patient driven. So if we can do anything to kind of brighten their day, they're stuck inside 4 walls, sometimes not even looking out a window that has anything but a view of a concrete wall. So, to bring a little bit of them into it. That's why we try to do a good job between therapists of just not just saying, hey, they're on this much oxygen and they're walking this far and they need this level of assist. We're saying, hey, this guy used to be working at, Crown Burger and he needs to be able to do this. And this is what really makes him tick. He likes to go fishing. And then that person knows you're not just seeing their numbers, you're seeing who they are, and then they're going to want to do it more. Makes them laugh.
And you see their life as a whole.
Yeah.
And trying to fit them back into their lives.
Yeah, absolutely.
Which is so, I don't want to say novel, but it kind of is novel for the critical care world, right? We see an acute illness, we see how critically ill they are. And a lot of times, especially if they're sedated and now that there's no family with us, we forget we not just forget, we don't get to know who these people are.
Yeah, that is a hard part. I feel like not having the family here, when they're intubated, normally it's yes, no, head nodding, maybe a little bit of this versus that as far as indicating when I'm asking questions, but the family usually jumps in and says, oh yeah, he goes downstairs and does puzzles every day and he's constantly out weeding in the garden and this and that. And it gives you an idea of what you're trying to get that person back to. And I feel like sometimes when they don't have family around to be able to speak to that former self that you're striving for, then you end up just kind of going through the motions if you don't. And I don't mean to say it's all for them. I think maybe sometimes it's a little bit for us as a therapist, just kind of helping these patients to have us be in a better mindset so that we're not just going through the motions. We get to know them better. The more you know a patient, the more you're going to fight for them. So when they're having that hard day, you're not going to, because they're having a hard day, just say, all right, that's okay. That's fine. We don't have to. You're going to give them maybe that extra 5 minutes to rest, and you're going to spend more of your time in that room in a productive and understanding way for them. So.
Ooh, I like that. Because I marvel at physical therapists. Sometimes people, especially with these COVID patients, they just seem depressed, despondent, anxious. Yet you come in, you're like, I know you're exhausted, but we're going to get up and party. Go. Yeah. And I'm like, how do you do that day in and day out? But that's so insightful that you see them as people. I know that sounds mundane, but you see them for who they really are, and you appreciate that, and that's what drives you to keep pushing them.
Mm-hmm.
And how different is COVID compared to other illnesses that we treated? Because a lot of times, in general, our patients are awake, totally clear, communicating, and these COVID patients seem different. How does that impact? What are you seeing, and how does that impact your therapies?
Well, I do think a big part of it is the fact that they don't have their families around. We know delirium can be brought on by a lot of things biologically and just environmentally, and that's, I think, one of the biggest environmental things right now in ICU is that versus somebody else that had, ARDS before and would come in, but they had their family members around. They had that grounding source,
Mm-hmm.
So we're having trouble being that grounding for them. So I think in a way, maybe I try to insert myself a little bit into people's, that I let them know, like, I'm here, I'm your support crew. I try to get to know them so that they know what I'm going to have them do. They know what I'm going to ask them to do, but they also, know that I'm knowledgeable enough to do it in a safe way. I try to teach them about what they're going through, both leading up to it. A guy that we've got right now who was on the medical floor and he didn't want to come down here because he was afraid of the ventilator. Basically, he didn't want to be intubated. He was just it made him so anxious, so nervous. And he came down here. He wasn't on it right away, but he knew it was a possibility, and that's why he knew they were transferring him down here, because he was kind of trending that direction. And I just had a really open, honest conversation with him about, before we could maybe speak to more, we see this all the time, and this is what's going to happen, and you just have to stick with it. Now we're having those same conversations, but we're saying, in my experience over the last couple months, this is what we know. This is what you could expect. So I kind of just try to lay it out for them, what bad could happen, what good could happen, but that we're in the now. Instead of, being afraid of this breathing machine, let's do what we know we can do now that's productive and positive. And I think having those conversations with them and letting them know that, we're going to do hard things, but it's going to make either how bad this gets be less bad, or it's going to give you something to divert your attention to. It's going to give you something that feels kind of normal.
Mm-hmm.
We're going to get you up and we're going to help you wipe your own butt. We're not going to put you back into bed. We're not going to lift your legs out of bed. We're going to ask you to do as much of it as you can. And I think if they feel empowered by you, that they can do what they can do, and you're going to help pick up the slack, but that you're always going to ask them to try, then they feel empowered that, okay, I know that if I'm feeling this way, but you're telling me it's okay, and you're going to let me rest, they start to trust that. And I think that's the hard thing is we do a lot of, I don't know right now.
Yeah.
I don't know how long you're going to be on this ventilator. I don't know if it's going to get worse before it gets better. And I think we have an element of that before all this, but you're hearing it from a stranger now versus me saying it and then a family member being there to reassure you of it.
Right.
So I guess, in that sense, it's different, but same. We just don't have that family element to kind of corroborate our story and kind of be there as a grounding force for them. So we pick up a phone and we FaceTime them in, we have them be there.
So you still utilize family in your therapies. Yeah.
Yeah. I mean, if I'm getting up and they're doing something that makes the family's experience from afar humanized as well, they can see, oh, he's sitting up. He's not just laying in bed, or yeah, he's got that breathing tube in, and the nurse has been telling me he's been able to write. They get an idea of what that is. It's not just writing one word, it's maybe they're writing sentences and they're able to joke and they're able to say things to have them realize that they're still aware of, say hi to so-and-so for me, make sure you update so-and-so for me, those things. So I think it gives them that chance to interact with them when they're being their most human self, they're getting up, they're doing things for themselves. They can kind of see, I don't know, that glimpse of just them being their selves that they knew before they dropped them off at our front door. Yeah. And
I have always seen physical therapy as such a huge part of humanizing our care in the ICU. Yeah. You keep them human, you keep them functional, you keep them strong, you keep them moving and able to do things. But it's so neat to hear that you're part of keeping them vocal, even on the ventilator. Yeah. You're giving them a voice and connecting them to their families. Yeah. I was oblivious to that aspect of it. Yeah. And that is so great. And when you tell people, like, for example, some of these people that come down, now we're doing oxymizers, high flow, and then intubating, if it comes to that, when you tell them and try to assuage their fears about being intubated, that you will be there, even when they are on the ventilator, they will still be awake and still be moving, and you'll be there with them. What does that do for them? Do they accept that well?
It depends on the person, right? I mean, if you go into it with the perspective that you trust the people that are taking care of you, and you are still, like you're going to be a part of your care, then it helps them. It helps them to know what to expect, right? They're not just a passive participant in this being taken care of. They know, okay, I know I'm going to have therapy twice today, and I know that even if things get worse, she's still going to walk in that door and we're still going to do what I can. And then I think that's the biggest thing, is that I always tell patients, like, I don't expect you to do the same you did yesterday. I expect you to do what your body can within reason, and to let both you and I feed into what that is, right? Mm-hmm. You might feel like you can't, but everything about your vital signs, everything about how much help I'm giving you, everything about what I know about your past and your history and who we're trying to get you back to says, yes, you can. Then we're going to push into it a little bit. We're going to try things that are hard, and you're going to rely on me. And there's moments where I just have to kind of default to the patients a little bit. They have to tell me when they need rest breaks more. There's a lot you can't see about this virus, because sometimes we're seeing either those numbers be fine and the patient is, breathing like crazy, or they feel fine and the numbers are tanking, So I think what it does for them is it just lets you know that you're not just willy-nilly saying, like, you have to do it. You've got to get out of bed. You've got to walk. It's just a part of what you do. It's okay. I buy in. Mm-hmm. I buy in. I know to expect it. I know it's going to be safe if we get to that point. And so if you tell them, hey, we don't know where this is going to go, but we are going to keep seeing you. We're going to help you get back to you.
And that's such a good point. There's a lot of fear with COVID, and reasonably so. It is a scary virus. It does crazy things. It's unpredictable. Lungs are severely, severely inflamed and damaged. And I think sometimes people imagine that we're whipping people army crawling on the ground blue, right? But you make a good point that we're doing whatever they can to their capacity. It's all personalized, and it's safe.
Yep. Yeah.
And there's been a lot of discussion since COVID started about the role of physical and occupational therapy, because reasonably so, there were a lot of concerns about PPE. Mm-hmm. And so it sounds like in a lot of places, physical and occupational therapy have been removed from the ICU.
Mm-hmm.
Any thoughts about that?
Well, I think it depends on if you're looking at the now or if you're looking at the future. And as doctors and nurses, and this is the reason I didn't necessarily choose that profession, you're in charge of their life now and in the future. But my perspective is to default more to what is your eventual quality of life after this? Do you get back to your former self? How long does it take you to get there? What's going to happen when a bunch of people that were allowed to live through this virus then need to get back to who they were, right? So if we're looking at the here and the now, yeah, maybe there's some rhyme or reason to in certain situations, and depending on where a certain city is or a certain facility is, maybe there's some rhyme or reason to, okay, this person can't do much. We've got a great nursing staff here. I can rely on you guys in certain situations to help patients do some of the basics, just basic mobility, right? But if we're talking about a facility that's extremely strapped and they aren't having that mobility happen at all if we're not in the room, then I think it's highly important if you're talking about their eventual quality of life and who they're going to get back to. So I think it just depends on what is the situation you're in. I'm in a great situation where I have people I can rely on that I know are going to move that patient to the extent that they feel like they can outside of my sessions. And I don't have to be on a prone team where all I'm able to do is just make sure we're preventing things. As far as pressure sores and helping to safely move and position patients, I can rely on my coworkers for that, and so in that sense, I'm using PPE, but I think we're being smart about it. I think we're looking at not just what we're in, when we're in the thick of it, we're looking at where we're going to be. And if we have all these folks that are then falling on rehab services outside of the inpatient setting, what did we do them a disservice, right? So
did we cause harm and damage?
Yeah.
And the PPE, I mean, I don't have any numbers on it. One of my speculations is when we remove these services, we prolong the time in the hospital. And I feel like that uses more PPE in the long run because they're here longer. I mean, we've sent home people that on nasal cannula that have been able to go home and continue to recover there and wean off the nasal cannula. But if they were still in the hospital, we'd still be taking precautions against them. Yet they went back to their families because their families were, were infected as well. So I don't know how we would even trace that, but I speculate that PPE use is equal, if not less, when we get patients better faster and get them home.
Yeah, I agree.
Well, thank you so much for all that you do and sharing your expertise and for being so creative in this COVID pandemic and for sticking it out with us. We need you. Thanks.
You're welcome.
If you want to join in on the conversation, leave a voicemail at 801-784-0472 or reach out to me on Twitter.